Welcome to episode 2 of the MRCS Part A revision series. In today's episode, we will be covering common shoulder disorders. These will include shoulder dislocations and their associated complications, rotator cuff injuries, subacromial impingement, calcific tendinitis, adhesive capsulitis aka frozen shoulder, and glenohumeral arthritis. Firstly, shoulder dislocations. These are one of the most common joint dislocations, and are seen frequently in the unselected take. The most common direction of dislocation is anterior. The mechanism of this is shoulder abduction and external rotation. Key things on physical examination, that will also be used in a question stem, are a loss of shoulder contour. Sulcus sign comment. There may also be mention of a mass in the infraclavicular fossa. Neurovascular examination is key pre- and post-reduction. Reduction methods are many, and include Hippocratic, Milch, Stimson and Cocker. Remember to check neurovascular status post-reduction. Pre- and post-reduction X-rays are also useful. Associated injuries with anterior shoulder dislocations are Bankert lesions, where the anterior glenoid labrum is avulsed off. Hill-Sachs lesions, where the chondral impaction from the glenoid rim onto the posterior superior humeral head can be large enough to lock the shoulder, making closed reduction impossible. The shoulder can also be dislocated posteriorly. These are less common, and when they are seen it is typically post-seizure or electrocution. On examination the shoulder will be locked in internal rotation. 50% of these are missed in emergency departments. On X-ray the key sign to look for is the light bulb sign. Associated injuries with a posterior dislocation are a reversed Bankert lesion where the posterior glenoid labrum is avulsed off, and a reversed Hill-Sachs where the glenoid rim chondral impaction to the humeral head similarly locks the shoulder, requiring open reduction. The shoulder can also dislocate inferiorly, though this is very rare. This dislocation is commonly associated with pectoralis and rotator cuff muscle tears, as well as glenoid fractures. Superior shoulder dislocations are also rare, and are commonly associated with acromion and clavicular fractures. Associated injuries with all shoulder dislocations are humeral neck fractures, which are more common in high-energy trauma and the elderly. Greater tuberosity fractures and rotator cuff tears are also more common in the elderly. Next to discuss is subacromial impingement, also referred to as chronic supraspinatus tendinitis. It is the most common cause of shoulder pain, and is caused when the superior cuff is pinched on the undersurface of the acromion and inflammatory bursitis. Patients will present with insidious pain, exacerbated when the arm is overhead. Pain typically occurs at 60 to 120 degrees of arc. Treatment begins with physiotherapy and anti-inflammatory analgesia. Next is subacromial steroid injections. Finally, arthroscopy and ACJ decompression. Next to cover is rotator cuff tears. There can be two types of onset with rotator cuff tears. The first is acute on a background of chronic subacromial impingement. This is common in the elderly. The second is an acute avulsion injury as a result of trauma, which occurs more in the younger population. In both scenarios the patient will complain of pain and weakness when trying to use the rotator cuff muscles. You may see the patient adjust their position when trying to raise their arm up from their side to bias deltoid. MRI is the ideal imaging to assess rotator cuff tears. Mild tears can be treated non-operatively with anti-inflammatory analgesia and physiotherapy. Large tears require arthroscopic repair. Note that long-term rotator cuff dysfunction can lead to rotator cuff arthropathy. This is the presence of shoulder arthritis with rotator cuff dysfunction. This is most commonly seen in chronic massive tears. Now let's cover calcific tendinitis. This involves calcific deposits within the tendons, commonly in the supraspinatus tendon. It's associated with subacromial impingement and presents with pain very similar to impingement. The pain is always atraumatic. The classic demographic affected is women aged 30 to 60, those with diabetes or hypothyroid. There are 3 stages to the disorder. First, the formative phase, where calcific deposits are laid down. Second, the resting phase, where the calcific deposits are stable, but the impingement symptoms persist. Thirdly, the resorptive phase, where phagocytic resorption takes place. This is often most painful for the patient. The preferred imaging modality is X-ray, where the calcific deposits are visible. Treatment is conservative initially with physiotherapy, non-steroidal anti-inflammatories, and potential steroid injections. Approximately 3/4 of cases with resolve within 6 months with these treatments. For those who continue to struggle, ultrasound-guided or surgical needle barbotage can break down the deposits. Open surgical excision is occasionally needed. Next to cover is adhesive capsulitis, also known as frozen shoulder. This presents as pain and reduced range of motion in the shoulder through all ranges. The disorder involves fibroblastic proliferation of the capsule tissue, which results in scar tissue and contracture. There are 3 stages. The first stage, freezing and painful stage. Second stage, frozen and stiff. Third stage, thawing stage, where shoulder movement slowly improves. Imaging modalities involve X-ray, more to rule out other pathologies. An MRI will show capsular contracture. Treatment for this is non-operative, firstly, with non-steroidal analgesia, physiotherapy, and steroid injections. It may take up to 2 years for the symptoms to improve. Operative management options are manipulations under anesthetic or arthroscopic adhesion lysis. Lastly, glenohumeral arthritis. This condition is seen mostly in the elderly population and presents as most arthritis joints do, with pain and stiffness over a gradual period of time. Imaging modality of choice is X-ray. These will show the classic symptoms of osteoarthritis, which are loss of joint space, osteophytes, subchondral cysts, and subchondral sclerosis. Treatment initially starts non-operatively with non-steroidal analgesia, physiotherapy, and steroid injections. If the osteoarthritis is isolated to the ACJ, arthroscopic debridement may offer some relief. If most of the joint is involved, then joint arthroplasty is the surgical treatment option. Total shoulder replacements can be anatomical or reverse. An anatomical shoulder replacement requires an intact rotator cuff, so a reverse shoulder replacement is preferable if the rotator cuff integrity is questionable. There is also an option for a hemi-shoulder arthroplasty, though this is used in cases where the glenoid is in good condition or the patient has multiple comorbidities and a long anesthetic is not desirable. Thank you for studying common shoulder disorders that can appear on the MRCS Part A examination with me. If you found this video useful, please like, and to ensure you don't miss any more study sessions, remember to subscribe and hit that alert bell.